that death has value. It's part of our lives. And at the moment, we are devaluing death by not giving it the space, not recognizing it. And by not giving it space, it means that when people confront it, it's suddenly very real, often in a crisis or with a very short time to manage that. So by allowing death to come back into life, the tagline of the Commission report, then we give space to it, we value it, and really bring it back in the rightful bookending of our lives, rather than colluding this idea that actually it won't happen. So it's such a pleasure to be here. It's lovely to learn a bit about your organisation. I was aware of it because I've been around in the field in public health palliative care, which I'll say a bit more about what that is, for many, many years. And Scotland is really known as a kind of incubator for a lot of this work. You've got some real kind of trailblazing projects across, rural islands, cities. So a lot of the world that I work with in terms of looking at where innovative practices are in this field look to Scotland. So well done on all the work you're doing. So I'm a palliative care doctor working in the community down in London. So I see people at home at the end of life, but mainly in the dying phase and the kind of pre-bereavement, much less around death care. And I think it's a real lack, and I'll talk a bit more about that in the presentation, but a real lack of the palliative care services. It just kind of ends, can feel quite abrupt. And actually a lot of palliative care clinicians who I work with have very little knowledge about death care, after death care, how you support families, different practices around funerals, etc., have very little to advise them on. And I'm also an academic, so I'm associate professor at UCL, looking at public health approaches to palliative care, so very much grounding it in social approaches. These are universal experiences, and how do we really transform them for everyone rather than just looking at a clinical model of care. So I'll share my slides now and take you through some of these points in a bit more detail. And has that all come through in full screen? Is that clear?
Yep.
Great. So we've got time for questions. But if there's anything really burning that you want to, then obviously just do interrupt me as we go through, but we'll have lots of time for discussion. So any thoughts, please do keep them, because I'd really love this to be interactive and get your perspectives and thoughts on some of the things I talk through. So I'm going to talk about the Lancet Commission on the Value of Death. We published this in 2022. And I want to start by kind of zooming out and thinking about contemporary challenges in death, dying, and bereavement. What kind of context, what landscape are they taking place in, and how are people feeling about these events? So the first thing, as we know, death, dying, and bereavement are universal events. There are a few things that happen across populations that really cut across everyone in a population, that everyone will experience and be affected by. And so it always surprises me that we haven't got more public health kind of population level interventions to support this. They're often treated as kind of surprises, failures of healthcare, strange events, rather than being universal events that we know everyone will face at some point in their lives. We know that life expectancy is increasing, and globally, this is a real success of public health and healthcare interventions. But we know that healthy life expectancy is not keeping pace with life expectancy, but also the dying phase is prolonged. So people are dying for much longer than they were in previous generations, when often illnesses were shorter and people died more quickly. As a result, people's familiarity with dying is decreasing. And often people are in much, much later life when they first encounter someone dying in their family or through friends, particularly someone dying at home or being present with someone who's dying or with a dead body. And for many people, they will never be in contact with someone at that dying phase or with a dead body, as increasingly we see that dying happens in institutions. So it's kind of behind closed doors. And that leads that further decrease in familiarity. People become less and less aware, and it feeds a fear. And so we see the impact of that within palliative care and within healthcare. One of the challenges is that death is seen only as a failure of health and not as a part of health. Now, obviously, in some ways, it's the starkest marker of inequity. That's a quote I often use. If you have an under five dying of a diarrheal disease or someone dying of a cancer that was entirely preventable, then that's known as avoidable mortality. Still a bit of a contradiction in terms, I think, but mortality that could be avoided if someone had access to good healthcare. And that's about inequity, people not having access to good healthcare and then dying as a result. But not all mortality is avoidable. At some point, mortality is unavoidable. It's a part of our lives, and I would argue it's a part of health. But at the moment, our healthcare systems are set up to see it only as a failure. So there's always one more course of antibiotics, always one more admission to try and defer death. But at some point, we know that can't be deferred. We know that there are significant inequities in accessing palliative care services, the same with accessing all sorts of services, healthcare or otherwise. There's a social gradient, meaning those who are experiencing deprivation or discrimination, low education, and other certain characteristics have a poorer access to services and support that they need. And often it's the people who are in the most need have the least access. And we see that in palliative care in common with many other healthcare services. And we know that the social and structural determinants, so the kind of broader things, the environment, the relationships people are in, the level of education, poverty or access to material resources, all of these broader social and structural determinants are not recognised at the end of life. They're recognised much more so during the life course, but not so much when someone then has a life-limiting illness. And this complexity is not appreciated. Often palliative care services or bereavement services look at much more straightforward. We need a telephone helpline, we need a counselling group, or we need a new guideline to help us manage something. But actually, these are complex social experiences, very different for every person, different in each different community. And this systemic complexity is not appreciated. This is a very busy graph with lots of figures in, but we, in the commission, the Lancet Commission, we had people from all over the world, high, low and middle income countries. And to try and illustrate how and where, why people die, we got a whole load of data from the different countries that were represented. So there was me, colleagues from Australia, from the USA, colleagues from China, India and Mexico, Malawi and Bangladesh, for example. And so we went and got all the data to look at what is the proportion of under fives dying, for example? What's the maternal mortality like in different countries? What's deaths from suicide like? Deaths from non-communicable diseases or deaths from communicable diseases, so prenatal, maternal conditions, nutrition, and things like just the crude life expectancy. And we saw really, really stark differences across why, how, and where people are dying. And these patterns aren't by chance, by random. This is due to the inequities in different countries and what access people have to healthcare, to good environmental support, to clean water, etc. So we wanted to kind of start by really understanding not everyone is having the same experiences in different countries or in different places within different countries. So we wanted to really illustrate those differences. In terms of understanding what these different inequities mean, it's helpful to think sometimes from practice. And so from my practice being a palliative care doctor, seeing people at home in the last weeks, months, or sometimes years of life, I spend a lot of time liaising with community colleagues to get a hospital bed delivered into someone's living room or into their bedroom to allow their skin to be protected, to allow them to sit up and feel more comfortable as they're increasingly spending more time in bed. But often I will go get a hospital bed ordered and in place and delivered, a huge task in itself. But I'll come back a couple of days later and find that the person's still not sleeping in it. They're still on the sofa and it's being used mainly as a shelf for pads or other things. And what the person says or the family says when I find out what's happened is that they have been struggling to make ends meet and they hadn't realised that the hospital bed required a plug to run electricity 24 hours a day. And often they were balancing so many different competing tight demands that they couldn't afford to have that. And I think increasingly as we look at choice, I use that term in inverted commas, but of where people would like to die, then the home as a place of care is where the majority of people want to be. But we have to look at some of the hidden economic costs and some of the social determinants which shape whether people actually have that as a choice and if they're able to deliver that. And I think that's something that we need some quite urgent policy attention to. A second example is with my colleagues in India and Kerala. So I've spent the past 20 years working with community-based organisations in Kerala who've got a really world-leading example of community-based palliative care. And they have spent many years reforming the opioid laws to allow pain relief for people who have got cancer-related pain, and have worked with all the local pharmacies to ensure it's available and free of charge for people who need it. But what the volunteers and doctors were realizing is that when they went to see people at home, they were still unable to take them because they didn't have clean water to take them with, and they didn't have actually enough food to eat. So again, it's looking at the wider context that dying takes place in, and understanding it isn't just a clinical intervention like a medication or a hospital bed, but understanding the broader context of that person and the family, but also the broader societal context in which these events are taking place. So one of the challenges when I give this particularly to palliative care service organisations, they often think, and I speak as a palliative care doctor, we're going to go in and fix all of this. But the problem with inequity is that more services can't address these bigger challenges. You have to look more broadly at a social response to these and understand that they're complex social events with medical components rather than medical problems with small social components. So, of course, we're talking about the social determinants of health. And this is what the WHO have done a huge amount of work on, understanding if you want to improve health, we need to look at the conditions at which people are born, grow, work, live, and age. Now, we know that some of you may spot what I would like to say is a deliberate mistake, the omission of death as a universal event and something to add to where we leave with age, ... And often this is an example of where death just isn't included in policy, it's not recognised, in documents it's not recognised, in the media apart from a sensationalised role of dying. Everyday dying, as Catherine Mannix describes it, is just omitted from so many different narratives. And this is another example of where one of the key life events that is one of the few things that is universal is not recognised as a part of the life course approach. So when we're thinking about the social and structural determinants of health, what is it that creates health? Well, we know that healthcare is important, but it's about a quarter, 15-25% of healthcare outcomes are due to healthcare quality. The remainder, so the remaining 75%, is due to the environment you live in, so your neighbourhood, the air we breathe, access to green spaces, the food we can afford to buy, economic stability, so your ability to buy the things that you need to survive, and then social and community context, the relationships that you have around you, the friends, the networks, the social capital you can draw on, and education, your awareness and how you're able to advocate for yourself, or your awareness of what is available for you to have. So these social and structural determinants of health really determine our health, and there's been a great deal of attention of them up to and including the dying phase. It only really looks at healthy well-being throughout life. And so this is another example of Michael Marmot's done amazing work on the social and structural determinants and what this means. And this is his diagram looking at how you go through the different phases. So prenatal, preschool, school training, employment, maybe family building, but again, leaving at retirement, and that continuing for to be omitted, this key point, this key universal life event that we know will happen to all of us is then omitted from that. Another example of where policies, research just are really not aware and not acknowledging the important life event of dying and death. So what we're asking in the Commission is really, what are the social and structural determinants of dying? What are they of grieving? What are they of these crucial experiences? How are we understanding the different components that we know are important in this life phase? Because that's something that really hasn't been considered fully before. I really like this article from Australia back in 2007, an old article now, Palliative Care is an International Human Right. And this is a quote from it. So, for if we are focusing on the comfort of a patient with life-limiting illness, surely that must include water, food, a habitable environment, warmth, bedding, and sanitation as much as symptom control. Indeed, it would be artificial to separate a right from palliative care from a right to general health, housing, water, and sanitation. All are interconnected, all determine good health, even and including at the end of life. And I think this is a really important lens for us to look through care in dying, in death, in bereavement, to understand that these broader determinants really powerfully shape experiences. And we can't talk about a right to palliative care if we're not also looking at a more general right to health, housing, water, sanitation, or whatever the relevant needs are of that person or that community. So coming now to the Lancet Commission. So we published in 2022. We started in 2018, so we ran for 4 years. We had 25 people across the world, and we had commissioners from high, middle, and low-income countries across different disciplines. There had been a palliative care commission a few years before, so we wanted to really move past that and look at death in a contemporary world. We looked at issues around gender, race, and power, alongside things like relationships, communities, healthcare services, philosophy and religion, consumerism, and economic perspectives. And we used a systems approach to try and bring a narrative, bring a thread through these really complicated, interrelated, kind of thorny issues to really bring a sense of clarity, both to bring critical perspectives, what's wrong, but also to be hopeful and intentional, to think about how we might improve things in the future. So the key summary points, it's quite a long document, but I would really recommend flicking through or looking online. We've divided it into different sections, so you can kind of read parts and see what ones you're interested in, skip over others. But we meant it to be quite a comprehensive document for people to really get to grips with the subject on. So the first is that dying in the 21st century is a paradox. And we were challenged, first of all, to say, is death over-medicalised? And we found many examples of where death is over-medicalised, particularly in high-income countries, but also in urban centres in low and middle-income countries. People are having treatments they don't wish to have. If advanced care planning or ceilings of treatment discussion exist, then often people are able to say no. But in many other countries where they don't exist or do not resuscitate orders are not commonplace, people are having very invasive treatments right until the end, and they're really unable to not have them. But we also see places where people are undertreated, both at the end of life in terms of pain relief or reversible symptoms, but also earlier in the disease course in terms of not having access to curative chemotherapy or preventative treatments for curable cancers. So it's not as simple as saying it's over-medicalised. For many in high-income countries, and certainly where I work, different side of the street, I can see people who are overtreated and people who are undertreated. And again, there are very different reasons as to why people are in those two different positions. We say, recognise that death, dying, and grieving today have become unbalanced, with a balance of control shifting into institutions, into the professional world, an institutional specialist model of care at these times, and taken away from communities, whereby that knowledge, that confidence is being lost, and people are feeling more fearful, becoming less familiar, and really ceding control to institutions. And institutions are often not best place to have that, and don't wish to have that control over it, but actually we're in a slightly unsustainable position where more and more people are dying in hospital, although in the UK the trends are changing, and fewer and fewer people are had been feeling confident to die at home, although those trends have shifted in recent years, which is a very welcome trend. We made some clear links with the climate crisis, the delusion that we're in control of, not part of nature, with the idea that we will defeat death at some point, that we're in control of death. And that idea is implicit to much healthcare research. There's always a new headline with cure Alzheimer's, cure cancer. And actually, there's no recognition that death is an integral part of life and a natural part of life. And that a lot of healthcare and research is pushed to this idea that one day we'll beat it. Rebalancing death and dying depends on changes across death systems, and this is what I'll describe. Death and dying systems are complex systems that shape how our experiences at these times are created. And we know that the disadvantaged and powerless suffer most from the current imbalance in death systems. We created a new vision of how death and dying could be, a realistic utopia, and I'll go through the 5 principles of that. And we recognise that this challenge of transforming how people die and grieve today has been recognised and responded to by many around the world. You are a perfect example of an initiative set up to challenge this. But we need more concerted actions. These examples are still not widespread. Not everyone has access to them, and they're not available across different countries. So radical changes across all death and dying systems are a collective responsibility. So why we took a systems approach is really encapsulated by this quote by Audre Lorde, who was a US feminist, poet, activist, academic, who said, "There's no such thing as a single issue struggle because we do not lead single issue lives." And death and dying really is it comes onto one of these examples where actually you can't separate how someone is dying, grieving, or caring from the broader, complex, entwined nature of the rest of their lives. And the problem often with palliative care or with clinical interventions is they try to separate that out. And we must look at a much more embedded way of understanding how this fits with someone's narrative, their life story, their good and bad things that have happened throughout their lives. So this is one of the diagrams we had in the commission. I'm increasingly calling it a horrendogram, and because the aim of it was not for us to work through it, not for us to examine different parts of it, but to illustrate the complexity. So this is a diagram just showing what happens at the end of life, all the different things that will be happening to that person, to their family, to the healthcare system, the legal system, etc. And we define this as a complex system. So the many interrelated social, cultural, economic, religious, and political factors that determine how death, dying, and bereavement are understood, experienced, and managed. And you'll see the different colours with the different layers. So there's the political, economic, and legal systems, human factors, socio-cultural system that shapes narratives. So all of these different parts are integrated. And the challenge so far, often in palliative care research or service interventions, is we're just using a magnifying glass to look at a few different issues. For example, access to palliative care and end-of-life care services, compassionate communities, or communication between healthcare professionals, for example. These are all crucial interventions, but often they're separate and separated out from the other things that are happening. So our challenge is to hold this complexity when we're thinking about how can we change a system, and then zooming down into the specific parts that we have control over, but always holding in our minds how they are interconnected with other areas. So I'll just spend a couple of minutes going through the realistic utopia before I close, this new vision of a future society where death and dying are rebalanced. So the first is that the social and structural determinants of death, dying, and grieving are tackled. So as I was showing before, these are really socially situated events, but we are seeing them through a clinical lens. So how can we bring that back? So understanding how people have lived affects the conditions, the framing, and how they will die, and how they die will affect the grieving of those around them. How that grieving takes place and how it's managed and experienced influences those people's lives as they go on, and will then influence their dying. So having a much more integrated awareness of how living and your health and well-being throughout your life affects the way, the means, the frame of your dying, and how that affects grieving. At the moment, things are separated out, and palliative care has actually been part of the problem with that. We're separating out and saying this is specialist care. We need to do this separately, and you need a clinical focus to manage it. The next is that dying is understood to be a relational and spiritual process rather than simply a physiological event. Now, this is something in hospitals is really being lost. In the home, it's much easier to bring these different parts in. But in hospital, it's about test results, blood tests, last treatments, chemotherapy, etc. And we're really increasingly seeing it's not being seen as the relational and spiritual event that it is, only as a failure of really physiology. So we really push for that to be prioritised and recognised, whether it's on a ward, in a nursing home, in a prison, in someone's own home. We know that networks contain a huge amount of resources, and often there's a focus on networks in terms of social networks, people's carers, their families, friends around them. But what we say here is actually these networks need to be broader. We need to have those local kind of inside network, but also we need there to be healthcare professionals, social care professionals, pharmacy, anyone else who's important in supporting that. So rather than having these slightly separate networks where often the palliative care team is separate to the doctor, the GP, to the community nurse who might be linked with the main carer or the patient, these networks need to have conversations and have lines of communication across them, because every person who is caring, dying, or grieving needs to have that network around them. And there's very good evidence that these social networks improve very hard outcomes like mortality. Having a social network around you is much more likely to improve your life expectancy and improve other outcomes like depression or other health indices. And so whilst in end-of-life care. We're not looking for obviously extending life, but we know they're very powerful tools for improving quality of life and well-being. And so we need to focus on how we build them around each person. Conversations, this is around really death literacy. And I don't know if that's a term that you've been using, but increasingly that's the term we're using to recognize the idea that there's a set of knowledge and skills you need to access these complex death systems, to navigate your way around, to advocate for yourself or someone you're advocating on behalf of, to make decisions and know what options are available. And so what we're advocating for is increase in death literacy for communities, for people who are facing end of life and their carers, but also for hospitals, GPs, schools to be death literate and understand that this is the natural part of life and need to be incorporated and rebalanced into conversation. And the final point is around death having value. And this was our most abstract concept, but I think the most important. And it's to say that death has value. It's part of our lives. And at the moment, we are devaluing death by not giving it the space, not recognizing it. And by not giving it space, it means that when people confront it, it's suddenly very real, often in a crisis or with a very short time to manage that. So by allowing death to come back into life, the tagline of the Commission report, then we give space to it, we value it, and really bring it back in the rightful bookending of our lives, rather than colluding this idea that actually it won't happen. So final thoughts here. That's the QR code for the Value of Death website. So there's lots of things like podcasts, webinars, more detail about the Commission report. And the final thoughts, a social model of dying, caring, and grieving is essential, as is a life course. And a life course approach to health and well-being must include dying and grieving. What's really crucial is to understand the death systems that we work in. We will each have a different system around us, professionally and personally. And the key thing is to understand it, know who's in there, know where the lines of communication are and where they're missing, and reach out across these complex systems to try and join those links and understand the role of each other. And then the final quote to close with is, death and dying must be recognised as not only normal but valuable. Care of the dying and grieving must be rebalanced. Thank you.
Thank you very much, Libby. How the final sentence of your report, finishing off that sentence, is we call on people throughout society to respond to this challenge. So that's what I'm curious to get ideas from people here tonight about how Pushing Up the Daisies might respond to this challenge in the work that we do, just in that small, very small part of time between someone's last breath and their burial or cremation. But first of all, just before we get into that, Libby, I wondered if you could say something a bit more about where anything else that's happening about since the publication of the report, or is there other work going on that you're aware of, or anything else we could be linking into from your side?
Yeah, so lots of people have taken the report and used it to reevaluate what they're doing. So if they're a bigger organization, look at revising their vision or strategic priorities, if they're writing policies for the future. Lots of people have focused conferences or kind of discussions around it, understanding what the principles, because they're quite high level, because we had to write them for a global audience. So the idea is they high level and you interpret them like, what would that mean for us? And you're absolutely right to think really locally. What can you do? And you've got a very specific period of time, a very specific window that you're looking at that does help you focus on that. So often, these are high level things like the social determinants. How do you begin managing that? But actually, one of the key things I think is understanding your local system that you work in. And often we're very used to working in silos, all the different charities, statutory services, social care, etc. And often there aren't good communication lines across them. And so often I think the first step is to understand your local system and actually getting people together who are working in it and just mapping it on a huge piece of paper. And I run lots of workshops with senior executives, with grassroots charities, where you just have a different colour for what's the law, what's about what charities providing, what does healthcare, what's with the GP, what's with medical examiner or mortuary services, funeral services. And you've got quite a clear intersection because you're working with lots of different organisations, both pre-death and post post-death. So you're quite a unique bridging organisation because a lot of organisations just work on either or. So you might find that you've got a really key organisational role in linking across the system and sharing knowledge across the system. Because I think in palliative care, for example, we're very bad at knowing anything about after death care, how that links up, how you can begin supporting people to have different options that aren't the classic one that they might not know about. But clinical teams often don't know about any of that. So one of your things might be, okay, well, let's map the system. Bring a GP or a palliative care person in if you know them who's already aware of the importance of your work, but actually drawing a more sustainable map across different areas because in the whole of Scotland there'll be innumerable different systems, but knowing what they are I think is the key thing because that's quite powerful to then illustrate where the gaps are.
Okay, we might need a little bit of help with that.
Libby, thanks. That was very inspiring and honouring your achievements to date and your achievements to come. That's so wonderful. Listen, I'm a builder, so I look at it from a perspective of the built environment. And for me, intentionality is the key to all of this work. And that's often expressed through the built environment. So that in Cornwall, traditionally the cottages would have a big hole in the first floor bedroom for the coffin to be lifted through because the stairs were too narrow. So that every time you walked into the bedroom, you'd see this trap door, and that would just signify, well, come the day.
Yes.
And I'm currently building a sauna on my land based on Estonian principles. And in Estonia, the saunas were used for birthing, but deathing, because they were warm, sterile spaces, because the smoke would get rid of the pathogens. And so every day you walk into your house or into your sauna and be embraced by that lovely notion of community death. So my question is, general question, how do we bring the familiarity with death back into our built environment? To give an example, I'm running a course in coffin building in Scotland in September, looking at how we can build coffins and perhaps build a coffin which we might use as a cupboard or a bookshelf in our houses which don't have death trapdoors. So I just like to register that thought, and the built environment is so important to our day-to-day appreciation of this. Thank you.
Absolutely, that's such an interesting set of reflections, and I didn't know about the trapdoor in the small cottages and also the sauna role. And I think the challenge with modern day society is that we've really kind of edited out all references to death. I mean, in Ireland, whenever I talk and do a similar talk to people in Ireland, they say, oh, no, we don't have that problem. The wake is such a huge tradition there that actually you have entire communities, thousands of people passing through. And whilst it's not pre-death, so it may not be supported with making decisions around decisions at the end of life, etc. Once the death has happened, there is a huge ritual that has its own energy. That is a constant reminder because there's always them happening, and because everyone goes to one, you're constantly doing that, and you talk very much around death, what it's meant. And I think that is increasingly being lost from many communities globally, the more traditional ways of remembering, of being reminded. And so we need to find new ways of doing that. And that may be for some people through religion or through stories, etc. But I think the built environment is so powerful because it's something, particularly looking at civic environments, it's something that everyone interfaces with. And that's why I think when you look at the social determinants framework, having that green built environment, the neighbourhood environment is something really important. So I think we need to find ways of bringing that back in. And there are discussion groups, etc. But often it's people who are already thinking about it come to groups. So you need to also be supporting people who, not by confronting them, because death is sad and the idea of losing people you love and your own mortality is really difficult. So it's hard to kind of push that. But I think how we can build that into environments. People in Belgium have done notice boards, places of solace. So if benches or notice boards, community, they talk, there's a way of writing, having a kind of poem or a prayer around things that that people have lost and people are missing. So there's kind of, you can create spaces for communities to come around to memorialize or to share their thoughts. But I think that's one of the things we need to focus. What are our 21st century geographical or built environment prompts? Because I think you're absolutely right. It's hugely important.
Thank you, Rory. Is there anyone else got any questions or thoughts about what we could be doing in Scotland? One thing I think is, which we sort of do on a small scale, is collecting stories and experiences and of being with death. That's one thing that we've started to do. That I know you mentioned that in your report, Libby. Yeah, so that's what we're doing, because what a lot of our work, or my work, is relating to carers and care and the relationship, understanding that relationship when someone dies. Because for children, it's now been understood, but only in the past maybe 20 years, it's been understood, the relationship with parents continuing with the relationship when a child dies. But for adults, it's just not understood in the system at the moment, that caring relationship. It can be really helpful to continue it for a few days. It's really important not to that takes its course.
It's looking good. Rory's getting some takers for the coffin workshop. I would love to come if I can get up to 5. They sound fabulous. And I think the tangible physicality of bringing that into the home is really important. I think it's really powerful.
Hi.
Hi, Jane.
Thank you. Really interesting for you, for really interesting report, actually. I'm based in London. I'm not in Scotland. However, I've just done an end of life doula. I'm an end of life doula now. So obviously you mentioned Catherine Malik
Yes.
and Alan Kelleher, and you had a fantastic conference up in Glasgow recently.
Yes.
Which I was not able to come to. But I'm kind of in. I've done this doula training and I'm now qualified. However, I'm also investigating all sorts of different sort of areas of this world, and it's fascinating for me because this is a completely different area for me. I had a completely different life, a different career before this, and so kind of working into this is quite hard, because it strikes me that there are just so many different kinds of people doing so many different kinds of research. And for example, I'm working also with a professor who's have you heard of COIN, community-oriented integrated networks?
Yes.
And he basically, we're looking at the idea of horizontal communication rather than vertical communication. So that carers and district nurses and doctors and everybody are on the same level rather than being siloed in the event of a person at the end of their life. And that is totally right. But it seems to me that what you're saying, you've also mentioned lots of things like, yes, we need to do this, this, and this, and this. And I totally agree with that. However, for me, the issue that I'm coming across in my sort of limited capacity at the moment is that I'm finding it quite difficult, because it seems to me that there are a lot of people who want to do all the right things and really try and make things better, but it's actually quite hard for them to do that. And communication within the NHS network is really hard. And people are not that willing to join together and create an inverted triangle. We need to be looking, in my humble opinion, and as I say, very new to this area, is we need to surely be looking at, the inverted triangle of community upwards rather than medicine downwards. And the question is, and you've said it yourself, I mean, we need to do X, Y, and Z. So we need to for me, the question is, how does one translate that into a proactive and effective mechanism to make change? That's the question that I have. And I don't know. Over
It's
to
an
you.
an enormous question. And even getting social and healthcare to talk, who are two professional organizations, is, an enormous challenge, yet alone understanding community power. And the problem is there is no parity in the system. There's deep, vertical, entrenched hierarchies. And so the challenge is with death, which is quite a marginalized kind of Cinderella service, not even I think mental health has had a great deal of focus, rightly so, on it, which has actually made it a really core focus of many kind of integrated networks or GP models, etc. But even that has not managed to really pull things together. So we're focusing on trying to get it into political. So the new palliative care policy that Scotland was focusing on, the new 10-year plan for England, there is a huge amount of work to try and get it in. But there's the difference between changing the entire system for everyone, yet alone just people who are at the end of life, for people who are young children, for breast cancer screening, for smoking cessation. All of it needs to be changed. So there's part of that which we've got to understand. I often feel quite overwhelmed because you can't do that. But what needs to be happening is, and actually to answer Nicola's question, so this, I've been giving evidence to a lot of the different palliative care commissions that have been set up in the wake of the Select Committee, etc. The Greater London, the London Mayor Committees, feeding into the palliative care policy review that Scotland did recently. So using this, the good thing about something like a Lancet Commission is it has a huge amount of weight and power. And so that's why I've been really focused on disseminating and using as much impact for that as possible. So we've inputted into almost every different policy on end of life, on death and dying, on palliative care. And actually it speaks 1,000 words because it's hard to get individual voices through, even if we are united, to really get that weight. Whereas actually this opens doors. It really has done. So what this has allowed, a very different perspective. This is not advocating for more healthcare professionals or more palliative care specialists, although, obviously we do need more healthcare workers. Is advocating for a social model. So I think people are quite surprised when I get in the door or when they start reading the report that actually it's a very different model. So I feel like almost like a Trojan horse, we've managed to get a very radical message in with something that has a very legitimate outside. And that's what a lot of people have said the power is. It's opened a door from them, like the Austrian government. They took it in and just said to the health minister, what are we doing about this? And actually it's much more powerful, unfortunately, than lone voices, although often lone voices are the ones speaking sense. So I would say, we've done a lot of work politically in the UK and globally, getting this onto the radar of people who can make decisions. And it is shifting. But as we know, social change is enormous. It's like a juggernaut, and how you begin looking at changing that. So what, at the same time as doing some of this bigger policy, you need to be working locally, building examples and trying to evidence it and share the story, because often there's amazing examples of local change, local innovation that never gets past a blog or something. So how you can share that more widely, because some of the really interesting research studies are picking up from a project that's worked somewhere, translating it and taking it somewhere else. And that's where you start getting spread. So I think it's being our own best PR agency to start sharing that. And the key thing, if you can create a flat hierarchy, a horizontal structure, parity within a system, and that's why I think, again, bringing people together in that system. So what you're talking about really is looking at the local system around someone at the end of life and bringing everyone together to have a conversation. If they know each other's faces, they know each other's numbers or email addresses, they will trust each other, and you will begin to have a very different form of communication if people are having kind of more anonymous conversations with a helpline or a telephone line. So I think the key thing, what I do in my area, is bring everyone together who's part of that system, have a workshop, a conversation, a cup of tea. It doesn't really matter. Everyone knows their roles. And then in that area, you begin changing the level of communication, because if you've got someone who's suddenly unwell, they'll have a conversation, someone coming out of hospital, someone who needs a care package, someone who's just died. There's a way of communicating within that smaller network. And those are the units of change that we have control over, whilst also trying to change the system, but we'll burn ourselves out if we try and take on the NHS.
No, I totally agree. I'm just trying to do that at the moment. I'm going down like rabbit holes and it's completely wrong. So I realize that actually you have to start small. And you're right. And it's not one size fits all, because each different area, each different community has different needs and prerequisites. So, one has to look at it in terms of it has to be a totally integrated network.
Yeah, exactly.
of
Yeah.
support. Yeah.
Yes, exactly.
Yeah, Nicola's saying she feels the solution should come from local communities
Yeah.
down up as well. Yeah, and she's a manager in the NHS.
She knows how complex it really is to get that change done. But I totally agree, Nicola. And
That's advice that people in the NHS gave me when with the start of Pushing Up the Daisies was to work on the grassroots. Don't try and change the NHS.
And then just share your story, and eventually it gets picked up, by potentially a new model, some research or something like that, that then you can do a kind of proof of concept. But you've got to do, that's where I did a lot of my work in hospice sector, because you've got much more freedom to start a new compassionate communities model. Whereas I've tried to do that in the NHS, it's absolutely impossible. So I've now gone elsewhere where the door at least is half ajar and I can push it rather than banging my head against a wall.
Yes, I completely agree that it's all a grassroots movement. And I think the one thing, and whilst that is incredibly slow, I also want to flag up how positive it is that there are now more and more growing organizations in little pockets who are really beginning to fly the flag of death, dying, and beyond. And I'm actually going to put Sharon on the spot here. She's laughing because we're both with the Soul Midwives Scotland, so exactly the same as what you're doing, Jane, just a different title, Soul Midwifery. Exactly the same thing. And like I say, I'm putting Sharon on the spot because she's got a story to tell. I don't know if you were going to or not, Sharon, but she's got a story to tell. But it's a story of positivity, of how the grassroots are beginning to move, slow but sure. And I'll just flag up that equally Soul Midwives Scotland are in the process of making ourselves a community interest company. And it's hot off the press, Sharon, but we've got really excited backing from a startup business advisor who is so interested in what we're proposing that he's really backing us all the way. So that's all about getting the word out to the public more and more and more. So I thought, so I'm just recapping to say, it feels very frustrating that it appears so few people are engaging in the subject of death and dying. It seems like that on one level, but on another level, there's actually a lot more who now are willing and keen and eager to be part of that conversation. So
I agree.
So yeah, because whereas you couldn't dare talk about death or dying, I was at a Christmas lunch a few months back, and I ended up talking Christmas lunch, but I ended up talking with the guy next to me about death, and he really enjoyed the conversation because although I started it, he actually carried on the conversation deeply because of his father had recently died. And it was like he said, it's just so wonderful to find that people are talking more about death and dying. So it's slow, but it's also mushrooming, which I think is the good news.
I hope we've reached the nadir of the death denying or the kind of wishing to not talk about it. I think it was many generations, decades before it was better. I hope we've reached the low and we're now coming out of that, but let's see.
I would like to think that as well.
Yeah.
Absolutely. Yeah.
Yeah.
So Sharon's unmuted and she's going to take over, I hope.
So my background is I work in a local hospice. I've been there for 8 years, and I found out about soul midwifery quite by accident, just doing some reading, and I joined the organisation and did my training with this lovely setup. And I've now set up an organisation in Lanarkshire called No One Dies Alone Lanarkshire.
Ah.
We're just in the process. We've registered at the end of last year. And I'm just in the process of applying for funding and things, and I've got a lot of backing from Business Gateway and our local social enterprise network. So just like Kathleen was saying, we're also a community interest company, and we've got 3 directors, and we've currently got some volunteers who are willing to volunteers about bereavement. I've got a counsellor volunteering, I've got a chaplain volunteering, I've got a complementary therapist, one of the directors, and the other directors in social work. So I think together we're trying to set up this movement. I've got lots of interest in my local area. I live quite rural where I live, and there's nothing in this community for people. So we're really excited. I've had great feedback from folk in the local area. I go to community council meetings and things just in different villages just to let them know. But then I've had lots and lots of good feedback and people saying they'd love to volunteer and do stuff for us. So there is one who has been a great help to me. There's one in Ayrshire as well. No one dies alone in Ayrshire.
Yes.
They're also Linda, who's the director of that's a sole midwife, so she's been helping a lot with that. So yeah, that's what we're trying to do in this area.
I've heard a lot about the No One Dies Alone, different initiatives, and they're really famous. I mean, my colleagues in Europe really look at all the work that's happening across, with Good Life, Good Death, Good Grief, but also the allied things and just the different areas that are doing things like Compassionate Inverclyde and the No One Dies Alone, and they're really reaching. It may not seem like it, but actually they're really reaching a lot of really interested ears across the world who are trying to understand how they may start up something that would be relevant for their context, but based on the same principles. So it's really exciting. It feels like a very innovative, kind of fertile ground for new ideas around in this space.
I have to say, although I work in a hospice, it's taking a bit of, I have to do a bit of explaining about what it is we're actually trying to do.
And that's the thing, palliative care, I think, is often not as open to innovation. It's quite set in its ways and it's quite restrictive. And actually, it literally just ends like a cliff edge when someone dies. And, you maybe get a call after 6 weeks. That's no help in terms of some of the real practical questions that patients or families have and patients have in the lead up to that. So we need to be much better at making links across the system in palliative care.
But can I just ask a question about that? You talk about that as sort of, yes, we do. Absolutely, we do. But I mean, in your area, for example, the lovely work that you're doing in Ayrshire, Lanarkshire, wherever, I mean, how many hospices do you have? And what is the level of government support in terms of hospice care?
In Lanarkshire, we have 2 hospices. In Ayrshire, there's 1. And in Lanarkshire, currently, the hospice that I worked in, when I started working, we had 30 beds. And then that was cut to 24, and it's now cut to 18 beds. That's a temporary measure, hopefully, because due to lack of medical cover. But we're still waiting on the NHS making the decision about whether we're going back to 24 beds. So I'm not quite sure about the like how many people, the population in Lanarkshire, but it absolutely covers nothing, the percentage of people who are dying. So I think there's definitely the need for other organisations to look at ways to support people.
So can I ask Libby? I mean, I'm 100% behind everything that you guys have been saying, but ultimately, I mean, surely, ultimately, the real question is, where is the finance coming from for all this incredible support? I mean, I work with a lot of hospices here down in London. I'm trying hard, and I work as a compassionate neighbour, blah, 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 and I work as an end-of-life doula, blah, blah, blah. However, I mean, I am acutely aware of the level of finance that is coming to hospice care and hospice at home care. And that, for me, is a really special and important part of what we're all talking about. So, I mean, Libby, how does all the consultative processes and everything, how does that sit with the level of financing that is actually being given?
So that's why there's the Palliative Care Commission. I mean, for years, that has been underfunded. And it's not just hospices. So I work in the community care funded by the NHS. So I think often there's a big focus on hospices seeing as inpatient beds. And, obviously that's important, but that's only one part of the landscape. So it's community care, and it's also generalist care. So district nurses who are available to give a pain relief medication. And so they're so chronically underfunded. I mean, parts of London that I know well, there's no district nurse after 10 o'clock. So you just simply can't have any pain relief unless you have a syringe driver set up. Obviously, rural areas means the distance can be prohibitive with a district nurse being able to get and give that. So, there's so many, it's the whole system. And I think the funding on hospices is a really key part because they are charitably funded and are raising, well, for a lot of the additional support, which is a challenge. But the NHS is paying for the bed days and the medical doctors and the kind of medication. So it's about how you fund all of that. But that is absolutely the crux of a lot of the clinical service intervention. But there's also the societal narratives and, the people talking of the people crossing the road because they are bereaved to come back because they have no sense of being able to say anything and no friends can actually find the words to have the question, to have the discussion with them after. So money is a huge part of it, but it's not the only part. And this commission wasn't about a funding review into clinical health services because it has been done in other areas. And it was looking at a focus on what else we need to do around that. We had a big focus within the report on the economic implications of overtreatment. So often this push to have endless courses of antibiotics, seeing that health spending escalates in the last month of life. And so if we were to really understand what benefit people got from that, and the Nuffield Trust have done a brilliant report. Anyone wanting to look at where the money is going, 4 in every 5 pounds goes into acute hospital care, £1 goes into community care. The majority of people want to die at home. There's no funding in it. If you could begin moving some money out of hospitals and other into the community, then you would have a huge amount of money. So the Nuffield Trust released it with Marie Curie recently, I think just the past month or so, looking at spending at the end of life. So that gives you an example. If we could just redistribute, because there is not a great deal more money in the system. And so that's a question when you're saying for more money, where does it come from? And actually what it should be doing is being moved from the acute to the community sector, because that's where people want to be. It's been chronically underfunded. And so that's the real shift I would like to see within palliative care, but within generalist as well. So it's not just specialist hospices, it's the district nurses, the care workers and GPs.
100%. And I totally, I mean, that would be great. Where could I see that report?
I don't know, if you Google Nuffield, I can have a look in a minute now, but the Nuffield Trust does lots of economic evaluations. So if you go onto their website, the Nuffield Trust, it's their most recent report, and they've done quite a lot of publicity around it. So it's a really useful one. They've basically said for every £5 on end-of-life care, £4 is in the hospital sector and 1 is in the community. Unless we rebalance that, we're never going to get anything done. So that for me is the answer. And it doesn't require more money.
I totally agree. Brilliant. Thank you.
Yeah, so that's what we need to push people for.
Thank you, because we've come to 8:30 now, and this is something we could be talking about all night.
Oh, I would love to be.
So yes, what I've taken from it is more stories, gather more stories and experiences and share them, and yeah, keep doing that. That's the message that I've got. If anybody else who's involved with Pushing Up the Daisies or has got another message, or from thinking about what Libby's kindly shared tonight after a day of work, so do get in touch with us. I'd love to hear your thoughts about what we could be doing here in Scotland.
And do share my slides, Kate. I'd be really happy for them to be shared. And that last QR code on the last one is how you sign up to the Value of Death, or if you just go to www.valueofdeath.org.
Right.
At the bottom, there's a sign up, and we're going to be pulling back the commission and looking at starting a really big global conversation. So if you'd like to be part of that, do just sign up there. And as and when over the next couple of months we start the wheels grinding again and we start planning our next steps, then you'll be part of that, and I can make sure that you get an email about our next steps, because I'm really keen that we pull in all organisations like you who are really doing this work to have a voice. And if I can amplify that voice through the work of the Commission, then so much the better.
Great. Okay, I'll do that. I'll share it around our network.
Great.
And okay, thank you everyone for coming tonight. That was great, and for everyone who's contributed, and we look forward to staying in touch. And if you are somebody that's new to us, you can, on our website, you can sign up for our mailing list. You don't get many newsletters from us, but you will get one if there's something happening. So if we have an event like this or anything happening on the ground, then we'll send out details. So thanks everyone, and good
Thank
night.
you.